Hi, my name is Dr. Stephen Fuller, and I'm the president of House Calls, a company that brings physicians to retirement communities. Nearly everyone who works in a retirement community will tell you how much they wish that they had a physician dedicated to their community. But regularly scheduled on-site physician care in independent and assisted living communities offered to all residents is simply not available in many areas of the country, and it's not at all available in my own state of Idaho. The potential benefits of physician care in these communities are so great, and the desire for this service is also so great. There must be a way of achieving it. Well, there are at least 3 basic models of engaging physicians with retirement communities, and I'd like to describe them to you. A table that compares the various features of these models will be shown at the end of this video. The first model is courtesy visits. This is where the physician or his practice may make an occasional visit to a retirement community to see perhaps a couple of their own patients they may have who live there. Going to the community is inconvenient and disruptive to the medical practice for the physician, so the visit is generally brief and occurs only when it's convenient to the physician. An example would be a physician who informally stops at the retirement community on his way home from his day's work. He may provide a limited evaluation for his own few patients, but he cannot see other doctors' patients, and he certainly will not provide regularly scheduled full primary care. This is the model that currently is practiced in my community and many others. It doesn't really work for the physician, and that's why he's so reluctant to go to these communities, and it doesn't meet the needs of the retirement community. The second model is medical directorship. This model is occasionally practiced in continuing care communities. That is, those large communities that include independent living, assisted living, and skilled nursing. The way this works is that the skilled nursing unit of the continuing care community hires a medical director, just as other skilled nursing units do. The job of the medical director is mainly to be the primary care physician for most of the skilled nursing patients, but because he is part of a continuing care community, he will sometimes provide care for a few of the residents in the assisted living or independent living sections. The challenge with this model is that the cost of retaining a physician in this role is prohibitively expensive for most retirement communities that consist only of independent living and/or assisted living. In Idaho, for example, the annual salary for a medical director in skilled nursing facility can range from $30,000 to $60,000 or even more, and most retirement communities simply cannot afford this. So this model may work for the physician, but it doesn't work for the retirement community. The third model is partnership. This model is new to Idaho and the surrounding states and was designed by my company, House Calls. The goal of the partnership model is to create a profitable practice for the physician on site in the retirement community. To accomplish this goal, House Calls creates an environment in which the physician, the retirement community, and the residents all work cooperatively as partners to ensure successful experience for everyone. Here's an outline of how this is done. On behalf of the physician, House Calls provides all the administrative support needed to allow the physician to conduct efficient one-half-day clinics once or twice monthly in the community. Residents are scheduled to see the physician, and the care is provided in the residence room. On behalf of the retirement community, House Calls assures that the clinics are run smoothly and efficiently and are scheduled such that they do not interfere with the normal activities of the community, nor do they distract the community employees from their normal duties. On behalf of the residents, House Calls establishes warm and trusting relationships with them and serves as a medical resource. We have frequent visibility inside the retirement community, making it easy for residents and their families and others to ask questions and schedule appointments. In return for creating this partnership of an on-site physician practice in the community with all the compelling benefits to the residents and the community invests a very modest monthly fee in House Calls for its administrative services. Now, this partnership model is new and it's different. And for some in the retirement community, it requires a little different way of thinking about how to engage physicians. It addresses the change in healthcare delivery that is occurring in our healthcare system today, and that is a focus of physician-led healthcare that takes place as much as possible in patients' homes rather than in the hospital. It also addresses the reality that retirement communities must actively participate with physicians in the healthcare of their residents. So these are three models of engaging physicians that are available to retirement communities. If you have a comment or would like to continue this discussion, then please leave a comment on our blog on the House Calls website. Thanks so much for listening.